Yes, doctors, we are good to start.
Yeah, I'm starting. Hi, good evening, one and all. Warm welcome to the webinars conducted by Yashoda Group of Hospitals, Hyderabad. Our today's topic is on management of pelvic fractures. Why we choose this topic is because this is a month of trauma, so called. So we just want to give some awareness, this thing, so that at least we can avoid one or two accidents. So trauma is not just like a person is getting affected or something like that. It's like a whole family is getting onto the trauma. It's like a family is getting affected, financially drained or psychologically drained, or whole family who is dependent on the person will get affected. So let's not neglect things. So let's be careful about ourselves. So now I request today's speakers, Dr. Brijesh Kidiyoor, who is one of the finest trauma surgeons, to give a talk on this. Now it's over to you, sir. You can go ahead.
Yeah, sure. Yeah. Hi. Am I audible?
Yeah, you can go ahead.
Yeah. Good evening, one and all. Thank you, Vinith, for such a mind-blowing introduction. So yeah, like you said, I think all of us would believe that like a family is affected, even when we are treating something with a pelvic injury, we should look at it as a team effort. The entire hospital has to be up for it in managing this, because it's not just one person, just the ER people doing the resuscitation, or the general surgeon or the orthopedic surgeon. It's a collective effort, and we need the ICU, we need the vascular surgeons, the interventional radiologists. The more the merrier. But the whole point is to take immediate decisions and move forward. So I'll start with my presentation. So yeah, like we know, pelvic fractures are something which send shivers down any orthopedic surgeon's spine. Reason being because the factors which affect the outcome are too many. But the things which we can do in a short span of time are highly limited. So getting the team together and getting the coordination going between all the teams, getting the OR involved, getting the lab and the diagnostics involved, plus establishing IV lines, it goes a big way in doing this. So yes, like Dr. Vinith said, it is a what do you say, a team effort where we have to put a lot of effort to save the patient. Isolated pelvic injuries have got a very not too bad prognosis, but when they are associated with pelvic injuries, abdominal injuries, and head injuries, the mortality increases multifold. And one of the main reasons why this happens is because of rapid blood loss. A patient can lose 2 to 3 liters of blood in a span of minutes without giving us time to really resuscitate the patient. So the first approach on the field should be just grab the patient. If you feel there's a pelvic injury, if you feel there's a dysmorphism in the abdomen is bloating post any high energy injury, scoop the patient and get the patient to a trauma center where he'll get all the maximum help in a minimum amount of time. So what they can do in the on-field is put a pelvic binder or at least tie a sheet if they feel that there is some bleeding happening. Open injuries, yes, it is very visible and very gruesome to see. But all the same, the earlier they reach the ER, the better we are to support them and to help them recover quickly. So the usual approach is as soon as they come, the ER team has already started the ATLS protocols. And once the protocols are being followed, same time we do the investigations. If the patient is temporarily stable, get into a basic investigation, maybe an X-ray, if possible, at least a CT scan on rare occasions. And then lastly, look for definitive fixation. So again, when the patient comes into the OR, the first thing will be a primary survey where we check the airway, breathing, circulation, establish the IV lines, look for a gross physical examination, and look for any pointers which show us the source of bleeding and whether there's a rapid fall in BP. And next thing, if the patient is reasonably stable and we've got some amount of a window where the patient is stable, we do a chest X-ray and pelvis X-ray. Next best thing we can do is a fast scan, which shows us any bleeding or which quadrant of the abdomen there's some bleeding. CT is not indicated until the patients are stable. So again, the same cycle goes over and over again. And I think in pelvic fractures, more than anything, we feel that the ATS protocol has to be done in number of times. The more you do it, the better for the patient, because every survey may show us different variables. So initial assessment, we see the hemodynamic status, we look for tachycardia, we look for cold peripheries, and we see the pulse and feel for the pulse pressure. ABG and lactate levels are good markers to help us identify what the patient is going through. And in the early phases, urine output is very indicative of how the patient is doing. So these are the practical things which help. The next thing which we'll do is, once we check the hemodynamic stability, the next thing will be the pelvic stability. These are the two cornerstones in the treatment of any pelvic injury. First, look for the hemodynamic stability. If you're good with that, and then you can simultaneously assess the pelvic instability. Pelvic instability is you hold both the iliac wings, try to draw them apart and compress them. So this should be done minimum number of times, but any movement should be taken as pelvic injury and a binder should be put. So an unstable patient, what we consider is BP less than 90 with a tachycardia and cool clammy extremities, and the tachypnea, and patient may be altered in consciousness. So when there is no obvious signs of hemorrhage and we are losing the patient quickly, the clinical examination should be robust in looking for the volume loss, in the sense whether the abdomen is expanding. You can keep a measure tape under the pelvis and check every 5 minutes whether there's any expansion happening. Any expansion means there's a loss of or there is a loss of the pelvic continuity, bony continuity, or ligamentous continuity. And after that, look for the groin, the buttock region, and whether there are any concealed lesions, which are very common in these. Any open fracture pelvis will show itself without any this thing, without any delay. But closed fractures which bleed internally are very difficult to note, because the containment of the pelvis is lost and it becomes like a balloon. It balloons out and you can lose 2 to 3 liters of blood almost immediately. So look for deformity of the pelvis. So laboratory markers, mainly, like I said, our serum lactate will help us see if there's any base deficit happening. ABG also will help us to make sure how his saturations are, and will give a rough idea of how his overall parameters are. In contrast, like we usually go for in regular cases, hemoglobin, hematocrit, and all do not really give us the idea of what is exactly happening at that particular time. A focused assessment of trauma with ultrasound guided aspiration usually hints to which area of the abdomen is involved. And the entire trauma series is kind of incomplete without the chest X-ray, pelvic X-ray, and the fast scan, which is done in minimum amount of time. So according to the WSES classification, we see minor, moderate, and severe. So with minor ranging to patients who can be stabilized in the ER, moderate comprising of who can be stabilized and shifted for imaging and probably brought back so that we can speed up, and severe, which is hemodynamically and mechanically unstable. So again, coming to the same thing, whenever a pelvic injury comes, first check the hemodynamic stability. If the hemodynamic stability is all right for that period of time, check the pelvic stability. Put in a binder whenever you have any doubt. Yes, there are some places where people are in doubt whether we'll injure the nerves, whether we'll injure the urethra or some bladder because of over compression of some fractures. But those injuries are very small compared to loss of life. So putting a pelvic binder, there is no harm. In fact, it can actually save the patient. The benefits we have of putting a pelvic binder and being injuring anything is much lesser than actually saving somebody's life. So once the hemodynamic stability is assessed, then we go for either definitive or temporary fixation, depending on how stable the patient is. If there's a severe lesion, then we have to go into a mode where we have to either look into taking to an OR for looking for the site of bleeding, or to the CT suite, so we can do a emergency embolization of the arteries. And along with this, we have to match our labs and serial clinical examination. There's no shortcut to serial clinical examination in these patients. So damage control. Damage control is nothing but trying to contain the amount of blood loss. lost. So what we do is previously we used to depend heavily on external fixators, but nowadays we get a good reduction of the pelvis and volume containment by putting only the pelvic binder. So the reason why we go for a pelvic binder is it helps us to shift the patient more easily. The pins don't become loose. And the thing is, even if you want to do some kind of minimal fixation, we can cut holes through the pelvic binder or through the pelvic sheet and put the pins in situ for temporary stabilization. Yes, initial management, I think Dr. Vinith is an expert with this. Most of the time we leave it to him, where he will hemodynamically stabilize the patient and if required, going for a massive transfusion protocol. At the same time, giving 1 gram of tranexamic acid within 3 hours is supposed to be beneficial, and the second dose in the next 8 hours, and which reduces significant mortality. But at the same time, we have to try to maintain permissive hypotension that is in the range of 90 to 100. A BP and BP of 80 to 90 at good urinary output and peripheral pulse not being felt means there's the resuscitation has not been successful. So we have to keep watching out for all these signs. Like I said, 2 to 3 liters of blood is lost. So replacing that is very important. Maintaining the warmth, that is maintaining the patient at the ideal temperature so that it doesn't go in for hypothermia. So like I said, massive transfusions and aggressive resuscitation, getting the IV lines, arterial lines in helps. The femoral and arterial and venous line go a big way. In fact, the femoral arterial line can be usually used by the radiologist, interventional radiologist, to put in a catheter and look for embolization or to do a riboa. And we have to look for chances of a lethal diamond, what is I think probably called now, where hypocalcemia leads to coagulopathy, hypothermia, and acidosis. And once we go there, it is very difficult to resuscitate the patient. So this is the application of pelvic binder, which is supposed to compress the pelvis. So usually what happens is pelvic bleeding is of two types, either venous or arterial. 80% of the times it is venous from the presacral and preperitoneal vessels, whereas 20% is from the internal iliac bleed, which is very difficult to control. So putting a pelvic binder like this is not acceptable anymore. So we have to make sure that there are no creases. This injury is because of an improperly applied pelvic binder, which makes definitive fixation later, and it doesn't give a graduated compression, uniform compression. It gives only compression in particular areas. So on the right hand side, you can see how the pelvic sheet can be applied. Same time, you can tape the knees and toes together to keep the lower limbs internally rotated, again to collapse the pelvis. So effectively, it reduces the pelvic volume. Have external fixator, but because of chances of pin loosening and not too much of stability, we are kind of moving away from this. And the patient finds it very difficult to set up or for us to mobilize the patient with an X fix. So we are moving more towards something called as a T clamp. A T clamp is something which can be put by residents in the OR, unlike the C clamp, which is on your right side, which has to be put specifically in the supraacetabular area. The T clamp can be put over the trochanters. So trochanters are very easy to find and usually don't disturb our definitive fixation later on. At the same time, because of the limited, lesser skill involved in that, it can be done more quickly, and the stabilization is almost similar. Next thing what we do nowadays is, if we have taken the patient to the OR, do something like an infix. So the infix is nothing but an external fixator, but underneath your skin. So it again works in the same way, where it reduces the pelvic volume, but the implant is not exposed. Especially with the genitourinary injuries and all, these are very helpful for treatment of open pelvis or injuries with genitourinary issues. And removed at 6 months. We have to explain that it may be the implants may break. So removal at 6 months is advised. So pelvic packing is the next best thing. Many times when the patient is unstable and we are losing a lot of blood, and pelvic packing into the pelvic brim and in the along with an X fix or an infix or a clamp, with iliosacral screws, or what you call as the stabilization of the SI joint with screws, and packing goes a big way. Along with this, we can also add embolization to help in the stabilization of the patient. So angiography and embolization, mainly when we are failing to resuscitate, or there's a large pelvic hematoma. So in that, even though the bleeding, like I said, can be up to 80% to 90% in the venous side, whenever there's arterial bleed, angiography has a good role. So, so like I said, repeat embolizations may be required in almost half the cases, and selective embolization is preferred with a skilled endovascular surgeon, or in interventional radiologists are also pretty equipped to do this. So, like I said, the 3-in-1 protocol, where they've done pelvic packing, X-fix, and angiography, all these give better outcome rather than just one. So, Riboa, or the endovascular balloon into the aorta, it can be put into 3 areas, but usually, because if you are looking at pelvic fractures, we look at zone 3. But the issue with this is there is a very high complication rate, where you can use it like a tourniquet for a maximum of 2 hours. And there have been reports of fasciotomy and compartment syndrome and loss of limb with this. But when it is essential, loss of life is any day a greater issue than loss of limb or any such issues. But our interventional radiologists feel that a selective embolization, angioembolization, is any day better than going through with this, because this is not more of a definitive thing. This is like a temporary thing until we can save the patient. So these are the particular zones, especially zone 3 helps with our pelvic arterial bleed. So associated injuries, especially when they're head injuries or pelvic, abdominal injuries, there is increase of mortality rate in the pelvic injury patients. Isolated pelvic injuries are not that an issue when compared with a head injury, because almost 50% of the patient base is lost when we have a head injury or an abdominal injury. So urogenital injuries also have a huge impact on the healing and the definitive process of fixation. So these can have associated long bone fractures as well. So primary internal fixation is done usually after 72 hours, when the patient has been definitely stabilized, and we have come out of the coagulopathy and acidosis and hypothermia issues. Post injury complications was supposed to be significantly increased when the definitive fixation was done between days 2 to 4. So it is preferable to wait for 6 to 8 days if the patient has been unstable, you're not able to reasonably resuscitate the patient. So again, take home message will be a pelvic binder is a very good tool to help stabilize the patient, at least temporarily, before we can get into definitive fixation. The only thing is that pelvic binder should be centered on the greater trochanter. If you put it a little higher, it compresses the abdomen, making it difficult to ventilate the patient. A little bit lower, it doesn't work. So the only take home thing from a pelvic binder point of view is center it over the GT. Make sure there are no folds or creases. Give uniform compression. And if needed, always, if we have a good check X-ray which shows adequate compression, and we can add our fixation percutaneous fixation onto that by cutting holes in that. So, and algorithm and management decision making is very important, especially massive transfusion protocols, giving the tranexamic acid, pelvic X-fix, and packing also have a good role. And angiography, embolization have shown reasonably good effect. And usually, whenever we have a cath lab in the hospital, we don't have to go for Riboa, but Riboa is like more like an emergency tourniquet which is applied at the iliac level, so that we can temporarily stabilize the bleeding or go in for a fixation. Yeah, thank you.
Thank you, sir. Thanks for the nice talk. Guys, if there are any questions, we can go ahead. I think there are no questions, sir.
I have a
Yes,
question
you
for
know.
Vinith. When do we actually look at starting a massive transfusion protocol? Because it's a big deal for us. How early do we look at starting it, or we let the intensivists take a call on that?
It's like when the patient hemodynamics, if they are not maintaining, if there is a HB drop, we'll do the sequential ABGs. If the lactate
Okay.
levels are growing, increasing, and HB levels are dropping, if the patient's BP is low, then
Yes.
better we go for, if we have a evidence that there is a blood loss, better we go for massive transfusion.
Correct.
Generally, after 4 units of blood transfusion, if it is not picking up, then they'll go for massive transfusion. Ideally.
Okay, okay. And what I understand after going through all this, there's no role of crystalloids or anything right now, or minimum.
Nowadays they are not using crystalloids. There are some post complications. So rather than
Okay.
that, if there is a blood available, then they are going with blood transfusions only. Crystalloids, like previously they used to use Hemazil and all, but now there is no evidence for it, so they stopped it. Starch, Hemazil and all. So, any other questions? Yeah, there are no much questions. Thanks a lot. Thanks for your time. I think you have a case one more now.
Yeah, I have to rush it. I came
Yeah.
in bit.
Thanks a
Yeah.
lot. I'll go
Thank you for the opportunity.
Thanks a lot.